oscillometry. Again, a warm welcome, sir, to Dr. Lennart, and the stage is yours.
Thank you. Thank you so much for this very, very nice and generous introduction. It's a pleasure to be with you, although it's like half a world away, literally. It's like midnight right around here in Montreal, and I guess you're just waiting to get your morning tea, morning coffee going. So, but that's the world we're living in. So yes, I'm a keelboat racer. As you can see, here's my boat. I'm gonna share my screen and start this lecture, and hopefully we will have time together. Please let me know if there are any issues with respect to the video part, and I'll try to fix things from my end. All right. So we're going to talk about oscillometry, and I'm going to give it a bit of a clinical touch. I mean, I also do these things in mice, as was alluded to in the introduction here, which is all very fun and so on. But of course, we all want to focus on humans and make sure that whatever works in mice also works in humans. Fortunately, most of the time it does. So for full disclosure, I am an employee at THORASYS. I have a small sliver of shares there, but I'm also the adjunct professor at McGill. So a lot of times I hear people talking about oscillometry as a new technique. And I just thought, wait a minute, is that really true? And of course, no, it's not true. The first reports actually came out in middle 1950s. So we're talking about something that is like close to 70 years old. So that's not quite new in my book, at least, not when talking about science. And so we're going to go over a bit of history, in fact, here, just to give you the full aspect of what has been done in oscillometry. But we're going to start with a lady and ask ourselves what's wrong with her. And we're going to talk about frequency dependence. We're going to talk about small airways. I'm going to talk a bit about how to do it, because that's, of course, very important, so that people understand that, you know, if you do this correctly, it's going to be a wonderful tool for you. We got a few clinical examples and stuff towards the end of my presentation here. All right, let's take off. We're going to start with a clinical example here. This is actually from my alma mater in Sweden, and Per Volmer, who I worked extensively with over the years. So he shared this with me. Some of the text here is in Swedish, but the gist of it, I sort of put translation into English, and I think most of the things you can recognize here. So this is an old woman. She's 82 years old. She got Sjogren's syndrome. She's got scoliosis, and she probably got another few things that I don't know. She was sent to PEAR for evaluation. They requested spirometry to evaluate her lung function, because they felt that that was probably not working really well in this woman. So they did a pre and post bronchodilator test on her. And I think the important stuff is down here, where you can see that bronchodilation did absolutely nothing to rectify her problems. So she left the place, you might think, without any further help being offered. Well, this is my nasty little thing. It's a cliffhanger. You will have to wait until the end to get a resolution of this. You can speculate as much as you like. Why is she not reversible? Why doesn't anything happen here? Well, we can think about that. But first of all, we're going to just jump into this and talk about, why do we want to do oscillometry in the first place? Well, as it turns out, it's all about the small airways. This is an image from 1963. Edward Weibel, he was a very, very productive and very smart researcher. He died just a few years ago, actually, very old. He was the one who actually discovered, or correctly identified, that we have about 23 generations of airways in our lungs. So this Edward Weibel in Switzerland, he did this with very, very smart technique. His papers are incredibly detailed and very interesting, but they also, right around the same time, started realizing that, well, the problems we are seeing in diseases such as asthma and COPD, they are not really large airways diseases. They are more small airway diseases. Somebody called this the silent zone. And the reason for that was that, well, they couldn't measure it. And the number of quotes out there, pointing out that there's a limitation with spirometry, that you need to have an engagement which some people estimate to be over 50% of the airway system before spirometry really starts showing a signal. Now, so this is a problem, of course. So how can we then acquire the knowledge about the lungs? Well, we need to do some mechanical measurements. And lung mechanics is nothing else but physics, applied physics. It's actually not very complicated physics, to be honest. I would say this is high school physics at best. So we want something that reflects the physical properties and the components of the lung. And we do this by measure three things, three variables. And the variables are pressure, flow, and volume. And those are the only three things we need to measure. And yes, that we can measure with them some success. If you haven't done these three things, I would argue you haven't done proper lung mechanics. Then we can relate these variables to one another. We can parameterize them, and the parameters then describe some certain specific aspects of what's going on in the airway system. The important thing is, of course, that whatever we do and detect, it should relate to pathology. And by that, I mean, we should be able to use it to diagnose people. We should be able to use it to monitor the patients. We should be able to detect if a treatment has any positive effect on the disease. We should be able to figure out if a patient is improving or declining in his or her disease. So those are the important aspects of any technology we use. So how is lung mechanics acquired then? Well, the classical one is to do spirometry. We have the patient to perform a maneuver, and the maneuver can take any shape and form you like, but the patient has to be with you, has to perform according to instructions and do it well. And if you're doing a multiple measurements, they have to be able to sustain and do this over and over again. So that's the challenge for patients, in particular those who are really sick. You can put people up in a plethysmograph. There's nothing wrong with that. Plethysmographs or body boxes, they are excellent tools for measuring lung volumes. However, as we will talk about in a little bit, they are maybe not the best tools to acquire resistance and compliance, or resistance and elastance of the airway system, unfortunately. Pediatricians, until the advent of oscillometry, were essentially flying blind when it comes to the lung mechanics, because there were no techniques that young kids could perform, because they didn't understand how to do spirometry. If they did, they may not have the focus to really sustain doing it properly and repeatedly. So that's a big issue. So pediatricians usually talk with the parents, talk with the kid, listen to the chest, scratch their heads, prescribe a medication. The kid comes back a few weeks later and see if they improved or not. And the diagnosis is usually asthma in that case. Imaging, of course, that's not mechanics, because it's a static image. But I'm listing it here because it has an important contribution to what we know about how oscillometry actually works, because we've been able to use imaging techniques to show how oscillometry can be related to certain aspects of the pathology or the structure of the lung. Essentially, what is known as structure and function. And imaging is, of course, a way of doing this without having to take out the lung from the poor patient. That has been done in mice, and it's been done in humans. There will be some excellent talks at ATS, if anyone is going there, where MRI will be discussed. One could also apply known perturbation or known signal. And that is exactly what we're doing in oscillometry. We are eliminating the patient's contribution as much as we can by just having a device deliver a test signal to the patient. So this, of course, makes the measurement different from spirometry, and it will also give somewhat different data. So it's very complementary and will give you a new piece to the puzzle. Also want to finally here highlight the differences in a couple of boxes here. Spirometry really is when the patient applies the test signal. Oscillometry, the device applies the test signal. Moreover, spirometry essentially answers the question, how readily could you empty your lungs from a total lung capacity? Whereas oscillometry is measured right around the functional residual capacity or volume. So those are things to remember. And just to really show you what I mean with this is that if we look at the volumes that we typically use in lung physiology, everything from the total lung capacity, residual volume and whatnot, here we have the tidal volume. Guess what? Spirometry is essentially this maneuver illustrated here, whereas oscillometry is an oscillating flow volume signal layered on top of the patient's regular tidal breathing. So the patient should not do any maneuvers at all. They should just sit there and breathe normally. So let's go back in history here. And this is so fun. I mean, I love this paper. I recommend it to anybody who has the faintest interest in oscillometry. You have to get this paper. It describes essentially everything we know and need to know about oscillometry. And they figured it out all in 1956. Of course, we know more today, but all the basic stuff is there and it's still valid. This was Arthur Otis and his colleagues who did this. So here's another author, Du Bois. And you can see here was a device in 1956 that had a loudspeaker here, a big bass woofer that provide oscillations. They have all the sensors lined up here. They have a spirometer for good measure, and they got a polygraph. So when this was done, guess what? They spent days upon days calculating the data. So this explains why oscillometry didn't start its victorious journey in 1956, really, because there were no computers around that people could afford or use to do the calculations, because they are pretty math intense. Now, let's go to Otis and his paper again. What they did in one of their experiments, this paper is full of funny experiments. One was to have patients and breathing at different rates. So they went from essentially 0, 10 up to 60 times per minute. And meanwhile, they measured the flow, volume, and pressure. And then they calculated either resistance or elastance. So we can see that there is a frequency dependence in this asthmatic individual. So if the patient breathes here down at like 5 breaths per minute, we have a higher value, and then it goes down. It's very striking in this emphysematous patient. We would probably call it the COPD case today, where you can see that the frequency dependence is really, really steep. So what this means is that if one were to do resistance, elastance measurements in a body box, for example, if one doesn't control the frequency by which the patient is breathing, one could end up with highly variable results that has nothing whatsoever to do with the patient's disease, but more about how quickly or slowly the patient is breathing. So this is a big problem, of course. It's still very good to assess lung volumes, of course, but I have my doubts about the resistance measurements. I'm going to give you another little tidbit here from Otis' paper from 56, and this is really at the core of oscillometry. It is the frequency dependence of lung function. Now, I want you to pay attention, first of all, to the left side here. Here we have a pipe, a big pipe here. It branches off into 2 smaller pipes, and they both end up into balloons. These balloons have the same properties, so they are identical. The only thing that is different from the left and the right here is that on the right-hand side, you can see there is a restriction in the passage here. So we have a much narrower pipe leading to this right side balloon. Now, if one were to oscillate or breathe very slowly in this case, that doesn't really matter, because the air will have time to penetrate the narrow passage here at the same rate as the large pipe. Just because the flow is so slow, it will have time to pass through here. If I want to be more sort of academic about it, we can say that this side here has a long time constant. This one has a short time constant. But that doesn't matter if we ventilate slowly. So inhalation, we will have both balloons expanded at the same rate to the same volume. If we then exhale or oscillate slowly out, we will end up at the same time with exhaled balloons. Now we're going to move over to the right-hand side where it says rapid rate. The same properties still apply. We're just changing the ventilation oscillation rate of this little module. Now, when you ventilate quickly, the air will not have much time to go into the right-hand side. What will happen is that most of the air will go into the left-hand side, as illustrated here at the bottom. And then when we exhale, which also is going to be a quick process, the left-hand side empties readily because there's a big pipe here, but this one will still have an air left in it. In fact, if we were to increase the frequency high enough, pretty much nothing would come through the right-hand side here. It would be as if it doesn't exist at all. So now you can think about this. If you have a lung where we have thousands upon thousands of these modules sitting, you can understand that the different frequencies will penetrate different sizes of airways to a more or less a degree. If we think about pathology where people might have variable dimensions of airways spread out through the lung heterogeneously, this will give rise to any number of combinations of modules similar to this with different size airways that all would impede the different frequencies in a different way. So this is sort of a convoluted way of saying that the different frequencies will pick up or be impeded by different size airways differently. And this gives rise to the frequency dependence of lung function, which was illustrated in the previous slide here. Now we're going to do another thing here, because that was essentially resistance. We were talking, well, oh yes, I have a quiz here. Now, of course, you may not be able to answer here, but still think about it. Which side has the highest resistance here? Well, had we been live, I would have been nasty. I would have asked you until I got an answer from you all, but I'm going to be kind. If we oscillate slowly here, the air will have time to go through the open pipe, which has low resistance, but also the high resistance pipe here. Whereas on this side here, the air will only have time to go through the low resistance pipe. Hence, when we oscillate quickly, we will typically measure a low resistance or lower resistance of the airways. However, if we oscillate quickly, we will now have a contribution here from the high resistance compartment as well. And this explains the frequency dependence of resistance. Now we're going to go to volume. And we have something called AX, which some of you might be familiar with who have already used oscillometry. If not, we will get into this in slowly here. It's also actually, I think, better to call it elastance, because that's approximately what it is. And it's a good representation of the elasticity of the lung. An elastic lung is a stiff lung. It's like a rubber ball that you can bounce easily on the floor. If a lung has low elastance, which it should have, that would be the equivalent of a non-inflated ball that just falls flat to the floor. So an elastic lung is a sick lung, a low elastance lung is a healthy lung, roughly. So I constructed a similar little module here as in the previous graph, We're going to oscillate in and out here with the same flow volume. It's identical all the time. Here we have a branching with two pipes that are fully open. We got two balloons with the same properties. I will assign them the elastance of 1. You can call the compliance of 1. They're just reciprocals of one another. So, but either way, elastance of 1. Then we're going to do an experiment here. We're going to totally block one of the limbs here. So no air can pass through this at all. It's a complete block. In real life, that could be mucus plugging, for example. We're still oscillating with the same flow volume here. Now is the question, what would the elastance be when we do this? All right, I'm going to give you a little help here. Elastance is calculated as pressure divided by volume. So this is volume dependent. Resistance is pressure divided by flow. So now we're talking about the volume, pressure divided by volume. In the case here to the left, any volume we inject into this module will be shared equally between the two sides. So both balloons will have the same volume. Because the balloons are of identical properties, they will also exert the same recoil pressure. So if the pressure is the same in both, okay, we're going to get elastance of 1 or compliance of 1. However, if we remove one of the balloons from this contraption, we still inject the same volume. Now this balloon to the left here will have to accommodate all the air. So it will get essentially twice as big as in the case over here at the left. When that happens, well, look at the equation, pressure divided by volume. Volume is still the same, right? But pressure, when you overinflate a balloon, you're going to attain a higher pressure. In fact, it's going to be doubled. So here we will have an elastance that is doubled. If we look at compliance, that would be in half. So that would be 0.5. So this is a way of understanding AX or elastance. So here we're now looking at the plots that we're going to get from oscillometry. I'm going to go over those in some detail in a moment. Here we have the frequency dependence of resistance shown here on the top. And down here, we can see that when this line drops down, that means that elastance is increasing because that's measured as the area over this curve here. Another way of thinking about this is that we oscillate a wave down into the lung, and depending on the frequency we're using, we will be impeded differently, as I said early on. The lower frequencies, like 5 Hertz, will penetrate and be not impeded at all through the whole lung, whereas the higher frequencies, while they will also penetrate the whole lung, they are impeded so much that in real life they are more reflective of the larger airways. And because we have this distribution of different sizes airways throughout the lung, the difference between the two will actually reflect the heterogeneity of the ventilation of the lung. And it all goes back to Otis and his paper. So if you read this paper and understand that, you will understand oscillometry. And the whole thing is then plotted on this oscillogram, where this letter Z actually is the impedance. That's the common abbreviation for that, or the sign for that. We have resistance at the low volume here. We have the resistance at high volume here. As you can see, there's a frequency dependence here. And the same is true for the what is called the reactance, but which is essentially reflecting the stiffness of the lung. All right, how do we do this? Well, you have to have a device, and here's the tremor flow illustrated. And we have a subject here supporting his cheeks. And that's important because we don't want to measure the impedance of cheeks. So all the pressure and flows need to go down in the lung. So keeping the cheeks supported with your hands is important. Also, we want to have a nose clip on so there's no leak, going back out through the nose, because that would of course give a false result for resistance. The patient just needs to sit there and breathe quietly, and when they do that, we click on a button and oscillations start, and they are layered on top of the patient's own breathing, like illustrated here below. And when that is done, it takes 20 seconds. You repeat it a few times, of course, to make a good average. When that has been done, the software takes care of the rest, and it will filter out the patient's own breathing pattern, and we will be left with the respiratory mechanics that is calculated on the oscillometry results, the stuff that we put in. Remember I said we deliver the test signal, so we actually want to get rid of this. And here's a little film clip that some of you might have seen ad nauseum, but nonetheless, I'm going to show it again here, and you can see how easy this is done.
And put this over your nose. Next, I'll need your hands over your cheek like this. Press it gently. Okay, I'm going to bring this up. Put it close to your mouth and put your lips over it. Open it. And breathe normally through it. I'm going to press the button now. Okay, you'll feel some vibration, but it's okay. Just breathe normally. Almost there. And there. Okay, now we're done.
Well, as you can see, that's easily done on a small kid, and it's obviously not a big problem for an adult human to do it either. So how do we interpret this? Well, first of all, you need to realize that the resistance is everything that has to do with flow. Anywhere there's flow in the lung, it will be lumped into the resistance component. Anywhere there's a change in volume, it will then go into the reactance or the elastance calculations. And in a normal, healthy adult, we should expect to see a resistance that is relatively straight line over the range of the frequencies that are being delivered by device. And the resistance we deliver is from 5 to 37 hertz, typically. Other devices might have different ranges. Some go only up to 19 or 20. Others go up to about the same as a terminal flow does, but they all sort of do a similar job. Resistance should be a straight line between 5 and 20 hertz if you're healthy. We're going to look at the reactance part. It has two components. One is the compliance or elastance curve down here. The other one is the inertance. Inertance is just the mass of air. And, you know, if you try to change the direction of a heavy object, you have to put in a lot of effort to change its momentum. It's like hitting the brake on a car. You will feel that yourself is pushed forward because you have inertance. And when you accelerate, you can feel that you're pushed back into the seat. So that is inertance. And air has inertance because air has mass. So the faster we oscillate, the more inertance will dominate what is the curve here. The stuff that is below here really pertain to the volume changes, as we illustrated in this cartoon a little while ago. So if you have airway closure, de-recruitment of airways, this will affect the curve. It will drop down. The crossing here with the x-axis will move out to the right. So high inertance is really just a sign that the lung is working as it should. It should move a lot of air in and out. However, the lung should not spend a lot of time not moving air. It should not have air trapping in it. It should not be stiff. So when that happens, this line drops down. There's another thing that can happen. That is that the tissue of the lung, the lining that goes around this balloon here, if you like, if that gets thicker and stiffer, that would also bring this line down. but the contribution of that is typically smaller than de-recruitment, because de-recruitment is a huge problem in asthma and COPD, COPD in particular, because it's almost not treatable. The outcome parameters, just to get into some more specifics here, is that we look at the 5 Hertz here, which is, as I said before, gives you a good idea of the overall resistance in the whole system. We have the 20 Hertz measurement here, and the difference between the two will give you this information about the heterogeneous small airways dysfunction that we talked about, only due to the different resistances that are sort of developing over in the whole lung system. Down here, we have this area over the reactance curve, which is then called AX. You can call it elastance, if you will, because that's approximately what it is. But it reflects airspace de-recruitment and ventilation defects, and to some degree also the stiffness of the tissue. So these are typically the 2 most common parameters that are being used. For, I would say, daily use, this is probably what people need to look at. So I've been saying that this represents elastance. Now, how can we do that? Well, it turns out when you calculate the area over this reactance curve here, you're actually going to get the units for elastance. It is pressure or volume, centimeter water per liter or kilopascal per liter, whatever units you prefer to use. So this is what it is. So I think, or hope at least, that you will have some idea about what resistance is and what elastance is. Resistance is how easy air can flow through the pipes. Elastance is really the volume of the lungs. So I think these are 2 concepts that one sort of needs to understand in order to adequately interpret what's going on with oscillometry, but they're not hard or difficult to understand, I hope. So just to summarize what we can see in terms of data in an oscillogram is that in a normal lung where everything is open and free-flowing, we should expect to see a resistance that has a line here that is relatively flat, at least between 1 and say 20 or a little there above. So we calculate this R5 minus 20, which is the frequency dependence. It should be close to 0. And R5 should be normal. And we have these ranges here that indicate what is the normal range. When it comes to the reactance or the elastance part, AX should be normal, meaning it has a low number. It should be in the typically lower single digits to be normal. And we can also see here that in this case that this patient has a high contribution of inertance, which, as I said before, is normal. That's good. Looking at somebody with a central obstruction, that would actually just affect the resistance. We can see this with people who develop a stenosis in the trachea, for example, after being intubated for a long time. But they don't have any issues down in the lung. They don't have like inflammation in small airways. So their reactance will be perfectly normal. It's just the resistance that shifted up. This is something you probably almost never will never see, but good to know if you ever come across it. What you will see, almost all cases will look something like this. People who have a heterogeneous obstruction, where there are these obstructions spread out over the lung, that gives rise to this frequency dependence. That gives rise to an increase in the resistance 5 minus 20 Hertz. So, of course, value here minus that one here, that's a larger number. So that indicates that there's something wrong. The area of the reactance curve here will, of course, go up. So we now have a stiff lung with a lot of de-recruitment. Again, it goes back to Otis. If you read this paper, understand it, you got it. So just as a little intermission here, what makes oscillometry so special? Well, it delivers the test signal. It means that there's minimal patient effort, which is good for most people. I think the parameters are intuitive and easy to understand because they're based on first principles of physics. And they will actually give you small airways information, which is important because that's where the disease starts and lives. It's quick because it doesn't require a lot of instruction and coaching and repeats from the patient side. And as I said, it's model-based, so we know what the data mean. It's an excellent monitoring tool, in fact, because it's so quick and easy to do. You can have a patient in and out in way less than 5 minutes, I would say. And it aids with diagnosis. So almost all diseases are clinical diagnosis, meaning that we look at so many different things in order to understand what's going on with the patient. Very seldom is there just one measurement one can do to diagnose a disease. So, but this is an excellent aid, in particular if you were to combine it with, say, for example, a bronchodilator test. All right, I'm going to move into the clinical utility of oscillometry. So that's really where we want to be, right? So I have a few examples here that I would like to share with you. And the first one comes from 1976. All right, didn't I say that this didn't really kick in until pretty recently? True, but there were some brave people already back in the 1970s who actually tried to do this. And Hall and his co-workers did. They recruited 16 adults with influenza. They did spirometry on them. They did oscillometry with the home-built device. It didn't have the range of frequencies that we have today, so they couldn't really report on reactance. So we don't have any data on the elasticity of the lungs here. A little sad, but they didn't know any better, or maybe they couldn't build a device that could do this. Either way, they did 4 different frequencies, and that turned out to be pretty nice and cool. They tested the people at time 0, that is when they debuted their flu, and then 1, 3, and finally 5 weeks after they were first diagnosed with the flu. They found out that FVC was normal, and FEV1 was 87% of predicted, which, as far as I know, is also normal. So spirometry didn't really tell them anything. Here is the data from their paper. So here we have the resistance in on average in all the subjects, and the open ring here, the top line here is at the first initial exam, so when they first showed up. 1 week later, for practical purposes, they had the same results. So resistance was still elevated, and pretty much actually. However, at 3 weeks, you can see that now resistance had dropped down, and at 5 weeks down here, they're now into the normal range. They did actually establish a sort of a normal range before they started the study. Here out to the left, they actually looked at the frequency dependence of resistance. So they did a slope construction between the 3 and the 9 hertz signals they had. So of course, not going to 20 as we do these days, but nonetheless, we can see that there was this distribution of people throughout, in particular in the beginning here. There were a few who were actually pretty healthy throughout, despite having the flu, but most of the patients were actually up above the normal range, and some were really up above. However, at the end of the 5 weeks, we can see there were only 2 of the patients who still were elevated. And I think this is interesting to note, because thinking back on the COVID that we just lived through, I would bet that this is pretty much what one would see with COVID as well, and any influenza for that matter. I've measured myself after having had a flu, and it didn't look pretty. So speaking of COVID, this is a study about a year ago from Finland. They, it's a bit complicated to read this paper, but nonetheless, in this side here, they actually had COVID-19 positive cases, and they had 2 visits with them. Over here, that COVID-19 negative controls, but these patients had something else. Presumably, they had the influenza. So what we can see here is that in either case, R5-20 here was significantly changed. So they had heterogeneous ventilation. Look here at the elastance. Elastance was significantly elevated, so they had de-recruitment in the lungs. So this is COVID-19. All right, look at the influenza then. That's this column here. Same thing. They had heterogeneous ventilation. They had de-recruitment. And interestingly, comparing visit 1 from the 2 different measurements here, we can see that there was a difference between the 2. So obviously, the people with COVID-19 did a bit worse than the people with the flu. At visit 2, there was no differences because people they had cleared. So these were cases that all cleared, and they had no long COVID or any, persisting symptoms after a few weeks. Monitoring asthma, as I said before, this is a very efficient way of using oscillometry. And this is a case from Montreal, actually. We wrote a paper a few years back, and this is my colleague, Ron Dandurand from a Lakeshore Hospital here. He uses Tremoflo and he's had it for 6-7 years, I think now. And this is what he does every day. People come in, he tests them, and they look good. All right, you're taking your drugs, fine. Now, this gentleman here, he stopped taking his drugs. So when he came back, let's see, about half a year later, his elastance had increased a lot. Look here, he had an AX of 6, which is not like super, but he's an elderly guy, I think. But now it's increased essentially tenfold, right? So that's not good. He also got the frequency dependency of resistance. Again, heterogeneous ventilation, not good. So he was told, reinforced, go take your drugs. And he was on budesonide formoterol. He got a little better, yes, but not perfect. So then they added a ultrafine particle steroid called cyclesonide, which he got BID, and he came back just a month later for a checkup, and look here, voila. Now he's back where he should be. He looks pretty healthy, right? So what does this tell us? Well, you can use it to monitor the asthma, of course, but it also shows, very importantly, that ultrafine particle treatment will actually penetrate into the small airways, and very likely that's the reason we got this good result. Because honestly, budesonide should take care of business, but it's not an ultrafine particle formulation. Cyclesonide, and they used here, was. So this is why it worked. Using bronchodilator test to determine asthma control is something that's been pioneered in Australia, and we're going to look at a couple of images from that. So why do we use that? Well, if there is remaining reversibility despite being on anti-inflammatory or biologicals or whatever, that could mean that there is room for improvement. And it could point to that inadequate treatment, or that there's something in patients' behavior that is actually impairing their asthma. So this could be cause for dose adjustment or other changes in treatment or advice to the patient. So this is a paper from Alice Cottee and her colleagues in Australia. And up here at the top, we look at FEV1. We can see that subjects with significant bronchodilator response using FEV1 was 13, FEC, there were 6 of them. However, using oscillometry, a lot more could be identified. So using oscillometry identified more patients who were reversible and could maybe benefit from a better treatment. Just to summarize that busy table, there was only one subject that had a bronchodilator response based on FEC alone, and it was identified more frequently with oscillometry. There were like 28 or 52 patients, and that's 54%. 15 subjects met the BDR criteria by elastance, but not spirometry. Only 2 subjects met BDR criteria by spirometry, but not oscillometry. So there were a couple that they picked with spirometry, but not oscillometry. So I think this shows that bronchodilator tests can, if you use oscillometry, identify poor asthma control. That's what they're arguing in the paper. Elastance are definitely more sensitive than resistance, and this supports the use of oscillometry to complement spirometry in the clinical management and monitoring of asthma and treatment efficacy. Going back to the paper with Don Dendron and a couple of others, here's a COPD case, stage 1. We can see it's, again, we see the frequency dependence here, slightly elevation in resistance, but elastance looks bad. It's got a value of 33 and some change. Of course, here we can see that spirometry is actually picking up what it should, because we stage COPD on spirometry results. So this is definitely a small airways disease. And Ron, he suggested that maybe one could actually use staging similar to the gold standards by using oscillometry. So he took 300 subjects and tried to plot where people should be. So we can see using AX as the cutoffs between 1 and 20, 20 to 40, 40 to 80, and above 80 would give 1, 2, and 3, and 4 stages. This is, of course, nothing that's been accepted, but it was a bit of trying to get a discussion going that we put out in the paper. Here we have stage 4. Again, FEV-FEC is 33% only, so this is a very sick patient. We can see that resistance, total resistance, the whole line is shifted upwards. It's frequency dependent, so not very good. Looking at elastance, 85.45, that's the area over here. And we don't need a number. We can just look at this and say that this is somebody who doesn't have good lungs. We can also look at the image here. We can see that there's a lot of emphysematous changes in this lung that were not present in the previous stage 1 lung. So this all reflects also the different natures of COPD as the disease progresses. But there's significant change in AX, R520, small airways disease. This is emphysema, a lot of airway closure, a lot of de-recruitment in this lung. And of course, this would qualify using Ron's staging methods here as a stage 4, of course. A few years ago, I was in Switzerland, and we looked together with a colleague there on asthma and COPD, because he actually routinely do bronchodilator tests on all his patients when they come in for a follow-up. So this is not like a randomized anything. We just took the patients that we found in his notes that had a clear diagnosis of either asthma or COPD. We didn't look at those who had, maybe other diseases or maybe had a mixed disease. So we tried to make it very, very clear. So we found 23 asthmatics, 22 COPDers, all regular patients coming in for follow-ups. So nothing special about that. Interestingly, the asthmatics, looking at R5 here, on average, they were actually significantly reversible. So again, if we follow Alice Coty's ideas, this would suggest that, well, there might be room for improvement here. But the COPDers, not a thing happened. Here we look at R20, nothing significant. AX, there seems to be a trend here for the asthmatics. It's not significant. Maybe a small trend for the COPDers too, but again, not significant. So I think in summary, this will suggest that maybe there's a difference between asthmatics and COPDers as well when it comes to reversibility. And I think that is true in most people's experience, that COPDers are much less reversible than the asthmatics, in particular if you have somewhat more severe COPD. The milder cases, yes, they can still reverse quite nicely, in fact, but as soon as they move into the territories of stage 3 and 4, the reversibility tend to go away. One quick here about lung transplant rejection. I'm not sure if any of you are taking care of patients with lung transplant, but this is a very, very nice technique to use in those cases, because nowadays rejection is diagnosed with bronchoscopy or confirmed with bronchoscopy biopsies plus spirometry. And neither of these is risk-free in a patient who had a lung transplant. There is always an increase for leaks to occur when you do bronchoscopies, and you could have pneumothorax happening. The nice thing is that we are now testing this with self-monitoring with the home oscillometry in addition to spirometry. So this is being done in Toronto as we speak. So here are 15, actually, yeah, I think there were 15 cases here. And they were followed every week after transplant with both oscillometry and spirometry. At the top here, we see spirometry. Here below, we look at oscillometry. As we can see, when they were diagnosed, they were significantly changed with oscillometry. Now, you have to remember, they got a biopsy every week to follow up. So it's not that they were diagnosed using oscillometry, but it turned out that oscillometry actually could have, in several of these cases, helped give the treating physician an indication that something was going on. And there's a big variability in oscillometry parameters leading up to the rejection discovery here. As soon as they're under treatment, the variability goes down, but moreover, reactance and resistance normalizes, which is, of course, the important part. And this was done, if they had used oscillometry instead of spirometry, they estimate that they could save 2 weeks. So diagnosing 2 weeks earlier than using spirometry alone. Here, another way of looking at the same thing, oscillometry, they discovered small airways diseases in all 16 episodes, and all 100% correctly identified as confirmed with biopsy. Spirometry, unaltered in 15 out of 16. So what is wrong with the 16th then? Well, turned out that that person actually had a round of viral infection just a week or two before the test was done. So in all essence, spirometry turned out to be pretty useless. IPF is a question I often get. Can we use oscillometry in interstitial lung diseases? And the question is very likely. I have to be honest and say it has not been investigated as extensively as asthma, COPD, or some other diseases for that matter, but those are the two big ones. So here we have some cases, again, from the same group in Toronto, by the way. And in these patients with diagnosed IPF, they found that they had normal resistance. And you can see here, this line is, there's a little bit of slope to it, but it is, for all practical purposes, a relatively straight line. It does not look like the COPD or asthma cases we saw before. So it seems like the elevated reactance area here, or the elastance, is actually what sort of provides the information that something is going on. There are studies ongoing. There's one here in Canada, and I think there are others as well going on, where this is being studied in larger cohorts. So we will see, hopefully within a year or two, how sensitive oscillometry is, how well it can be used to diagnose. But I think it's sure, because these are already diagnosed, right, that we're looking at here. If you have somebody with a diagnosis and you see that the elastance is increased, well, then you probably can also use it for monitoring. That is my guess. This is the conclusion that I just copy-pasted directly from the paper. The data provide a cogent rationale for adding oscillometry in IPF assessment. So that's what they thought. So there are a couple of different renderings of oscillometry, and what is being used in modern devices such as a TremorFlow and Resmon is a multi-sine wave signal that has all kinds of frequencies mixed together. And that makes it for a very efficient way of doing oscillometry. There's some very primitive devices out there where they stage and give one frequency after the other. The problem with that is that the breathing pattern or the lung volume might change from the first to the last. In fact, we know when you put a mouthpiece in the mouth of any of us, we will actually change your lung volumes little by little as time progresses. So it's a bad idea actually to have these sequentially different frequencies delivered. There's something called impulse oscillometry. Now, impulse oscillometry is also oscillometry, but it's a special case oscillometry. So we shouldn't call anything IOS or impulse oscillometry. Impulse oscillometry is actually a brand name. So unless you're using a device that is doing that, well, then it's fine. Here on the left, we do actually have data from an impulse oscillometer. So here's correct to mention that. They discovered something that was kind of interesting. Look here at the bottom here of the reactance curve. You can see that there's like a little hook on the curve here. They contacted me and thought that that was, had some physiological meaning. I said, no, it actually doesn't. And we know this because we've done some work on this. So here is a similar measurement using a thermal flow. What is the thing? Well, they start at 5 hertz here, right? See, 5 hertz, that's the adult signal. However, if you use the pediatric signal starting at 7 hertz, then you're going to get really nice recordings here. So what is happening here is nothing but it's essentially just a mistake in the use of the equipment. Using an adult signal on a child is wrong for this reason, and that is that children breathe at a much higher frequency than an adult, and they breathe actually so quickly that the harmonics of their ventilation or tidal rate will actually bleed into the 5 hertz signal. And this is why you get this artifact. So this is all artifactual. So any calculation of AX here will be wrong because you actually eliminated the biggest contribution to the elastance calculation here. So whenever you want to do pediatrics, you need to use a device that actually can start at 7 hertz. So the differences between oscillometry and impulse oscillometry, sine wave oscillometry and impulse oscillometry is really a lot. There are design differences, linear motor designed for low frequencies. The impulse oscillometer has a loudspeaker, which is designed for audible range and not for low frequencies. We have a high precision of flow of pressure and volume, whereas the loudspeaker has no feedback or control of any of that. The continuous sine waves means that we're measuring continuously. There are no interruptions where there's no measurement happening, whereas with pulses, there are always breaks when nothing is happening. We're using prime numbers, so that means that we have no harmonics, no interference can happen in the signal, whereas a pulse always contains unspecific frequencies that will interfere with one another. And we actually do deliver frequencies over the whole range of interest. But with impulse oscillometry, only the basic frequency is generated. The rest are actually harmonics that came from the speaker just because it's flopping back and forth. Because there's a good control in modern devices, we can actually correctly scale the amplitude to optimize signal over noise. And that is very important in order to get a good quality signal. Whereas with a deflection of a speaker, you're only going to get whatever the amplitude is when the speaker is popping from one extreme to the other. And we do have a dedicated pediatric signal, which is not available because of the shortcomings of the impulse. So I'm almost done. 2 more slides. I want to bring up this question. It's sort of just nipping it in the bud because I always get questions about the correlation between oscillometry and spirometry. And in fact, it's relatively poor. Here we have 450 subjects that my friend Per Wollmer in Lund collected, mix of healthy and COPD people. As you can see, this is like the shotgun approach of making a plot. Yes, with so many plot measurement points, you're going to get a significance, but the explanatory value, the R value, is ridiculous. It's so low, so it's really worthless. Yes, here is an R of minus 0.2, but the p-value is still ridiculously high. Of course, it doesn't matter that doesn't mean that there is a correlation. This has no explanatory value whatsoever. So how can we use oscillometry and spirometry? Well, essentially, I think this is a good plot because this illustrates that the two technologies do measure different things. It doesn't mean that spirometry is bad. It doesn't mean that oscillometry is good or vice versa. It just means that these two technologies measure different aspects of how the lung is functioning. And you can use this to your advantage by understanding how the different technologies describe the lung and henceforth make the puzzle laying much, much more efficient. All right, the final one. This is a graph where we have spirometry down here, normal spirometry, abnormal spirometry, oscillometry here, normal here, abnormal. Okay, so these are typical ways to compare different technologies, right, and see what kind of the quality is. So in the extreme corners here, we have healthy people, right? Everything is good. Both techniques give negative results. Here we have those who are identified by both techniques as having a some sort of abnormality. And then we have here the ones where oscillometry actually detects something, but spirometry didn't. And in this corner, the opposite, where oscillometry failed to detect something, but spirometry did. All right, let's see what it looks like. All right, so starting up here, this is, of course, interesting because this indicates that there are small airway pathologies, but they're not as bad, so bad that spirometry will detect them. This is also where lung transplant examples end up, as I just showed you. Ultrafine particle response, as I also showed you, will be up here. And maybe pre-COPD or early COPD will be here too. That's our suspicion, at least. Down here, well, there are a few. It turned out that this is about 4%. The most likely explanation is that there are some cases, and I've seen some with alpha-1 antitrypsin deficiency. They tend to inflate their lungs a lot. They breathe at a higher and higher lung volume as the disease progresses. And they do so to compensate for the increasing resistance that is and de-recruitment is happening. So this is the most likely reason for some will actually show up here. Mind you, they have to have a lung disease that is so severe that spirometry can detect them, because if they're mild, they wouldn't be detected in any case. All right, now we're back to Our Lady. What do you think we're going to do here? Of course, we're going to do oscillometry, right? Stupid if we didn't. Okay, here we go. This is her pre-measurement. This was done with an impulse oscillometer, by the way, just so we understand why the images are slightly different here. We can see that her resistance is slightly up here in the abnormal range. She's not like super high, but she is definitely elevated. Her reactance, her AX, is really big. So this would suggest that she has de-recruitment and some heterogeneity, of course. All right. Well, you know the answer. I wouldn't show this if there wasn't a positive effect, of course. But it turns out that this poor old lady, she's fully reversible. She got down to her normal for resistance, and her AX is up to normal. So why didn't this show here? Well, we don't know, but my guess is that she's old, she's frail, she has a number of different chronic diseases. We don't know anything about her mental status, to be honest, either, but I think it's enough to look at what's listed here to maybe she was not really up to the task to do a good spirometry. So, but here's the answer. she could actually go on some sort of asthma treatment probably and do a lot better, feel a lot better. All right. I think this shows that bronchodilator test can be very revealing. So I think, and I hope that you now understand that this is new, not a new technique, but its implementation these days is much more advanced than it used to be in the 1950s. But the central concepts were already established way back and were known from the start. I hope I conveyed to you that it's good for diagnosis and it's really excellent as a monitoring tool. And it can be used in asthma, COPD, lung transplants, ILD. This seems to be a very, very powerful technique for that. It's based on first principles, which means that we can understand that the structure, how the lung structure and function relates to what we're measuring, which is important. And old ladies can actually be fully reversible if we use the right technology to understand what's happening. Thank you so much for your attention. And if there's time for any questions, I would be happy to take them.
Thank you so much, Dr. Lennart. It was very nice to listen to you for almost 60 minutes. You were able to capture the audience despite the complexity of the topic.
Thank you.
So, do we have any questions, both from the online participants? Any online participant wants to have some comment or questions? Yeah, Dr. Srinivas.
Thanks for that excellent talk, Lennart. Pleasure to hear that. So I have a question about your, like, in terms of reversibility. Is there a lot of data on what is a good cutoff on oscillometry to define reversibility? Is that different for, say, R5, R520 and AX, or is there like a standard number that you would use for?
Well, this is where your own expertise has to come into play, because there are several publications out there, and the reversibility is primarily, I think most people use it for resistance, but also for AX. And you can find publications where they suggest 28% is significant. You can find those who say that 40% is significant. That's a huge difference. I think it reflects to some extent the type of patient, or the not the nature of the patient, but their age primarily. So if they're children or if they're adults. So one has to use one's own judgment actually to decide that. There are some technical recommendations, but the most recent ERS recommendations were based on a group that had primarily children, or a large portion of children in there, and they acknowledged that in their paper. The older version had more adults in them and had a lower cutoff. So, but somewhere between 30 and 40, I think that's the best I can tell you. But then you will have to convince yourself that that is good. I think there'll become more and more data on this as time goes on. Yeah.
Yeah, thank you, Dr. Lennart. Wonderful. This presentation on oscillometry, we learned a lot. We always learn, and that was wonderful. So question is first is a comment only, that I think that old lady did a good spirometry, graphs were good, but oscillometry probably, I think, is more sensitive. So it detected that she still has a reversible airway disease. The second, my question is, like pediatrics, you showed that the frequency starts from 7. So is it the inbuilt in the system, or because we are doing it and the graphs are coming directly? So I think R5 is still there in that.
Yeah, you have to choose it. Yeah. So, but that's, the customer service can show you that, or if you find it, but it's up in the left-hand corner. When you're going to do a new measurement, there's a pull-down menu, and just select that one, and it's 7 to 41 or a 5 to 37, whatever. Yeah. So, but you have to choose it.
Thank you. And the third one is same on reversibility. So there are three parameters now. It is R5X5 and the AX. So which one you seem like most important, or all three are important, or which way it should be interpreted, or even one will do?
It depends, because patients are individuals too, right? And I think in particular, when you look at asthma, some asthmatics, they have really twitchy airways, and you will see a high value for resistance. Whereas others, they tend to suffer more from peripheral airway closure, and they will have a much bigger AX. So I think it's actually a bit more patient individual rather than us deciding that one parameter is more important than the other parameter. Looking at the whole picture and seeing that you see sort of this, it's almost like a trumpet, it bulges out. That is sort of the thing I can eyeball, and I see quite quickly that, oh, I have an idea what's going on. What is really nice, I didn't talk about it here, but if you look out, at least on the tremor flow, we give something called Z scores, which is a statistics which you can use. And if that means if you are 1.65 standard deviations away from your normal, expected normal value, then it's abnormal. And that is the same value for all parameters we give. So you don't need to remember different percentages or anything like that. It's 165, above that, okay, abnormal. Of course, that's a statistics measure, but well, that's how we define things in our world in science. When something is statistically different from the expected normal, well, then there's something wrong. I'm not sure if that answers your question.
No, thank you. Thank you very much.
Thank you, Dr. Lennart. Any other question from the audience, online, offline? If not so, sir, can I ask my personal question, having listened to oscillometry, so much of advantages? What is your opinion on the future of spirometry?
Oh, spirometry. I think spirometry has a great future in the right hands, because it captures what is going on when it comes to the full lung. I mean, the elephant in the room here for oscillometry, and I alluded to that in my last slide, is that there are some few cases where people actually will have very highly inflated lungs. And I'm not so worried about those, because we know they are sick, right? And they will be sick no matter what technique you measure with. So in those cases, I think you could use the one or the other, and maybe spirometry would be more sensitive, just because when they exert themselves and really empty the lungs, well, then you will see the closing volume, and you would see that they have abnormalities. However, if you were to look at them when they were starting their disease like 20 years ago, then I'm willing to bet you that spirometry would not be very sensitive. So I also think for now, in interstitial lung diseases, until we have more information, that the slow vital capacity might be still a very good measurement to use for that. That is something that is pretty well established in the ILD business. We just don't know how sensitive oscillometry is in order to diagnose early. There's just not any information on that yet.
Okay. Thank you once again for taking your precious time, almost past midnight. Thank you.
It's almost 1 o'clock here.
It's 1 o'clock. So we just quickly finish. We, as a token of appreciation, I may request Mr. Arnab again to receive the memento on behalf of the management. So this is the THORASYS team, actually.
Thank you. Looking good for you too. All right.
So thank you, Dr. Lennart. We will move to the next session now.
Okay. Thank you so much for having me, and looking forward to meet several of you in real life when I come to NAPCON